Bismillahirrahmanirrahim. Assalamu alaikum everyone. Good morning. I am Dr. Masab Umair and I welcome you all to today's webinar, which is on the topic of assessing the Mpox threat and the challenges and solutions for Pakistan. So before I start, I would request everyone to please make sure that your mics are on mute. And if you have any questions, you can drop them in the chat box. And at the end of the presentation, I'll try to answer them. And just in case if there is a issue in the link, I will make sure that we share the link with you in the chat box so you can rejoin, just in case there is a disconnection. So I'll give a background about the disease, then I will very briefly discuss the global situation, and then I'll talk about the national update and response that is carried out at Pakistan, and then some of the challenges and what are the solutions that we think. So looking at the historical events, Mpox, so the first time it was detected in 1958 in captive monkeys, which were, and the research was done in Denmark. So a first human case was detected in 1970 in a 9-month-old child. And this was basically reported from DRC. In 1980, smallpox vaccine was discontinued and the disease was eradicated from the world. So this also is very important when we talk about Mpox, because we know that smallpox vaccine, it provides some protection against the disease. So it had implications, especially implications in the spread of disease after the 1980s. So between 1980 and 2000, early 2000, Mpox cases was basically confined to Africa, mainly Central and West Africa, and they were intermittent and sporadic cases reported from these countries. In 2003, it was the first time when Mpox case was reported outside Africa, and this was basically due to you can say, import of African rodents that were infected, and they basically the virus was transmitted from these rodents to prairie dogs, also called the ground squirrels, and these are basically kept as household pets. And so these prairie dogs, they were shipped to US, and from there infection in human was reported, and around 47 cases were reported in 2003 in US. If we look after that, the next coming 10 to 12 years, there were cases reported mainly from Africa. In 2017 and 18, basically the Nigeria, there was a reemergence of this disease, and cases from Nigeria, they were exported to countries such as UK, Singapore, Israel, and US through international travel. And 2021 was the first time when Mpox cases were reported to non-endemic countries. And in July 2021, the outbreak was declared as a public health emergency of international concern. In fact, the first case basically during this outbreak started from a patient that traveled from Nigeria to UK, and then following there were cluster of cases reported in UK, and then the disease spread to other European regions and the Americas. However, this public health emergency of international concern was uplifted a year afterwards in May 2023. And there was different, public health measures that were taken that were responsible for the uptake of the public health emergency of international concern or the removal. And in 2024, there has been a surge and you can say a rise of Mpox cases in the Democratic Republic of Congo. And we have seen that it has been a source of exportation of cases to neighboring countries such as Rwanda, Uganda, Burundi, Kenya, and we have also seen few cases reported in Thailand and Sweden. And also in August, on the 14th of August, this outbreak was declared as a public health emergency of international concern by WHO, and on the 13th of August, it was also declared as a public health emergency of continental security by African CDC. So I think this is the first time a disease has been declared as a public health emergency twice in such a short span of time. So if we look at the global trends from 1st of February 2024 until 31st of July, so there have been 1,154 cases reported on average monthly. And the most affected regions are the African region, where most cases are reported. Our cases are also reported from the region of Americas and the European region. Looking particularly at the epidemiological situation in African continent, so we can see that WHO has confirmed 7,658 cases along with 54 deaths. And this is the data up till 25th of August this year. So in 2024, there are 14 countries in the African region and with 5,281 confirmed cases and 32 deaths. So case fatality rate of 0.6%. But if you look at the stats of the Africa CDC, so there are more than 22,000 suspected cases and 622 deaths have been reported. And it is believed that the cases are much more than this. And the reason why they are not detected is primarily because of the lack of access to diagnostic testing. And obviously, there are a lot of asymptomatic cases. So it is believed that the burden of Mpox in Africa is much more than that has been reported so far. So 3 of the top countries that are affected, Democratic Republic of Congo, DRC, basically is the epicenter of this outbreak. And a high number of cases are reported in its neighboring country, Burundi, and also in Central African Republic. So if looking at the distribution of Mpox clade, so Mpox clade, as we all know, they have implications on disease severity. So clade 1 is believed to be more severe and case fatality of 10% has been reported in different studies, whereas clade 2 causes much milder cases and symptoms, and its case fatality, if we look at the 2022-23 outbreak, it's less than 1%, it's around 0.3%. So at the moment, you can see that in the Africa, especially in the Central Africa, in DRC, clade 1 is circulating, and clade 1 has further 2 subclades, clade 1A and 1B. So both these subclades, they are reported from DRC. And if we talk about the neighboring country, Rwanda, clade 1B is prevalent. Noticeably and alarmingly, 1B is increasing exponentially in Burundi. And I think, again, this is a cause of concern for the continent as well as for the world. So we have seen that one case of this clade 1B or this variant has been reported from Sweden and from Thailand. So the case in Thailand was the first case reported in Asia. And all those countries in orange are the ones where clade 2 has been reported. And if I talk particularly about the 2022-23 outbreak, so clade 2 was the dominant clade, and the lineage that was more prevalent was the B.1. So most of the cases were attributed to the B.1 lineage. A look at the phylogeny, you can see that the 2022 global outbreak was due to the B.1 cluster, as I mentioned previously. And if you look at the bottom of your slide, you can see that the clade 1 has now 2 segregations or 2 clusters. One is the clade 1A and the other cluster, which is the new variant, also called as the clade 1B. And these cases, as I mentioned, the clade 1B cases, they are increasing in the DRC and as well as in Burundi. One of the important things, as I mentioned, WHO declared this 2024 outbreak on 14th of August as a public health emergency of international concern. But they also made some temporary recommendations, and then they have also extended the standing recommendations up till August 2025. And some of the key recommendations are that all the member states, they should develop and implement a Mpox national plan. They should establish and sustain lab-based surveillance. They should enhance community protection. Research and innovation is an important recommendation. Then applying measures for international travel. Although it is recommended that strict restrictions such as screening both inbound passengers and exit screening, it's not recommended. Also, there is no need for doing looking at vaccination certificates or testing for these travelers. And also coordination and equitable access. I think this is again a big challenge during this outbreak, the equitable access to vaccines, to diagnostics, and to therapeutics. There is also a global strategic preparedness and response plan that has been developed, and the aim is to stop human-to-human transmission. So it has three areas, and the main aim is to rapidly detect and control outbreaks. There is a need for advanced research and access to countermeasures, and then the One Health approach to minimize zoonotic transmission. So this document is also available. And I just wanted to highlight that a very unique, approach has been taken by the African continent. They launched the Continental Preparedness and Response Plan for Mpox outbreak. And this is for September 2024 till February 2025. And this is again a very unique strategy being used by the African continent, where they have decided to make a one team. So there will be a one incident command management system. There will be a one plan, and it will include activities for all the countries that are affected in this continent. And there will be a one budget, and there will be a one monitoring and evaluation framework. So again, this is going to be supported by different development partners such as WHO. So I just wanted to highlight this because again, this is a very, I believe, unique plan and a unique strategy that is being used by the CDC Africa. So coming to the response actions that Pakistan has taken during this current public health emergency. So just before the start of the declaration of public health emergency of international concern, our National Command and Operations Center was activated. Some of you may know that this NCOC played a key role during the COVID-19 pandemic, and I think it was central in controlling the disease in the country. So obviously during emergencies, one of the major challenges is coordination between the federal and the government authorities and different stakeholders. So NCOC is the right platform which tackles such challenges. So this platform was activated earlier this month. Then the International Health Regulation Committees and technical working groups have also been activated at the national and provincial level. A national advisory has been issued, and guidelines which were previously issued during the 2022 outbreak, they have been revised and they have been circulated among the key stakeholders. There has been a strong engagement of all stakeholders and development partners such as WHO, such as CDC, UKHSA. So NIH is in collaboration with all these stakeholders. We are doing assessment of point of entries and designated health facilities. In fact, this has been done, and our point of entries, the screening is being carried out for suspected Mpox cases, both at airports and then at land crossings, and also at sea borders. So, and we have implemented these screening measures, as I mentioned, at the 3 point of entries, and then we have initiated a process of provincial public health laboratory network assessment. So we are providing supplies and kits to our provincial public health labs. Also, genomic sequencing. It was started back in 2022 when we started doing Mpox testing in the country. So this is primarily done at the NIH level, but our provinces, they also have these capacities. So the notification of focal person and isolation in quarantine facilities has been done at the provincial and at the federal level. And there has been training of lab personnel and surveillance personnel conducted both at national and at provincial level. And different, IEC materials, they have been developed and disseminated to communicate this and engage. So regarding the algorithm that we are using for detection for the lab diagnosis of Mpox, so any suspected case that has a lesion, a sample is collected from that suspected case and it's tested for Mpox virus using real-time PCR. In case a sample is negative, the result is communicated to NIH and to relevant health authorities. Similarly, in case of a positive result, not only the case is reported to the relevant authorities, but we do the clade differentiation at the national level at NIH. At the moment, we are not using Mpox specific clade, you can say PCR assays that are available, but we are doing next generation sequencing to detect which clade is prevalent. So whatever we have sequenced, we share the sequencing data at GSID. All the data is submitted on GSID, and we also report this data to our health authorities for different response activities. So in Pakistan, there are 7 different facilities where Mpox lab testing is being done at the moment. So we have at the national, at the federal level, NIH is leading this testing. Then we have our 4 provincial public health reference labs, each in the 4 provinces. They are part of this network. We also have private sector, our university is part of this network. So we have a consortium, you can say, or a network of labs that are involved in lab-based testing. And if, as I mentioned, the Mpox testing was started back in April 2022 at NIH. In April, there were 22 suspected cases that were tested. However, no case was found positive. In 2023, 142 cases have been tested, and among them 9 were tested positive. And if we look at 2024, this is the data till 28th of August, 61 suspected cases, they have been tested for Mpox virus and 3 have been confirmed. So overall, 225 patients, they have been so far tested for the detection of virus. So these are the PCR results. As I mentioned, in total, Pakistan has reported 12 cases as of today. The first case was reported on the 19th of April, and this was a traveler who returned from Saudi Arabia. The sample was referred from PINS to NIH. We managed to detect the case, and we also managed to do the whole genome sequencing of this sample. So we found that clade 2B was the clade that was detected, and the lineage 8.2.1. Similarly, on the second case was detected on the next day in April, and we have also detected 4 cases during May. And in August, there was 1 case, and similarly in September and December, 1 case was also reported. One of the key thing here to highlight is that all of these cases, they had travel history, and they had travel history from Saudi Arabia. So obviously there is prevalence of this disease in that area. And interestingly, we managed to do second sample from that year as well, and that was the same clade reported previously. So one of the patient died, unfortunately, due to the disease. And in January, 2024, so far 3 cases they have been reported. Again, all the 3 cases, they have travel history from Gulf countries, and we managed to do whole genome sequencing of all the 3 cases. They again belong to clade 2B and 8.2.1. So looking at some of the clinical and demographic features of these confirmed cases in Pakistan, you can see that in 2024, the case number 10, 11, and 12, they belong to Islamabad and KPK, but again, they were travelers, 2 from UAE, 1 from Saudi Arabia. And previously in 2023, most cases, they were reported from Punjab. Looking at the clinical features of all the cases, they had lesions, mostly on forehead, some had on face, and some on genital organs. And fever was also a common clinical feature that was reported in these patients. So this is the phylogenetic analysis of the 4 cases that we have done at NIH. So as you can see that the triangles in blue are the samples that were sequenced during 2023, and the red are the ones that are recently sequenced during the 2022-24 case. And all of them, as I mentioned previously, belong to clade 2B, and it belong to lineage 8.2.1. If you look at the homology of our sequences, so most of the samples or the sequences, they showed high homology with strains that have been reported from US in 2023 and India and UK in 2022. I'll very briefly talk about the 8.2.1 lineage. Again, this is a very rare lineage. Very few cases of this lineage have been reported globally. And it's really, important to note that all the 5 cases that we have sequenced so far, they belong to this rare lineage. And previously, this lineage has been reported mainly from India. So obviously, there is a need to do more research and investigate the circulation of this lineage. This is one of our study that we published back in 2023. So the first case that I mentioned, so basically we carried out whole genome sequencing of that sample using a metagenomic approach. And we managed to do or retrieve the whole genome of the virus within 48 hours. I think, again, great, I would say, efforts from our team working at NIH and at our virology department. So interestingly, not only we managed to retrieve the whole genome sequence of the Mpox virus, but we found that the patient was also infected with VZV, varicella zoster virus, so which causes chickenpox. So this was a case of co-infection with VZV, and we also managed to do whole genome sequence of this virus, and we found some unique mutations in that. And if anyone is interested in reading that paper, this is available. You can download that. So we issued national guidelines for Mpox back in 2023, and then now we have revised. The updated version is also available on the NIH website. And this basically addresses different components such as surveillance, prevention and control at the point of entries. It discusses in detail about laboratory diagnosis. There are a lot of confusions, I know, that about what sample to take, how to transport it, and how to do testing. So all this information is available under the laboratory diagnosis chapter in this guideline. There is also a chapter on safe handling and waste management, then risk communication and community engagement, and lastly on infection prevention and control. So lastly, I'll talk about some of the challenges that we are facing in Pakistan regarding surveillance and in response to this outbreak. Although there is no human-to-human transmission, or no case has been reported locally in Pakistan. All the cases so far reported were travel-associated travelers. And as I mentioned, so far there are just 3 cases reported this year. And all of them, they have recovered. So there is no case reported in the local community so far. So some of the challenges that we are facing at the national level and at the provincial level are the limited diagnostic and sequencing capacities. And the main reason is that obviously they were limited PCR kits that were procured, and however we are working on that. At the moment, there is no clade identification PCR kits that are available in the country, but NIH is in process, and hopefully we will be in a situation where we will be able to get these kits on next Monday. So I think, again, this will reduce the time, the turnaround time that is required to differentiate the clade. So if you talk about sequencing, it takes 2 to 3 days. So using these specific PCR kits, I think this will greatly reduce the turnaround time. And obviously, sequencing capacities is a huge challenge. NGS, we all know it requires expertise, it requires infrastructure, it requires bioinformatic expertise and infrastructure. So we need to strengthen this and at the national level and at the provincial level. Obviously, again, I need to highlight that next generation sequencing is also a costly technology. So there is a challenge in that area as well. There is a limited access to countermeasures. I think this is a challenge that is being encountered by most countries globally. So there are limited vaccines available, and obviously therapeutics, they are limited. And we have heard about the Tico-Virimet, but the recent trials of this drug in DRC show that this drug is is less effective against the clade 1B. So there will be challenges of vaccine and then availability of the therapeutics. So this will be same for Pakistan and for some other countries in the near future. I think communication and community engagement is very key. And we foresee that there will be some challenges, especially given the fact that there is some stigma associated with this disease and some misinformation and disinformation that is spread in the local communities. And we have seen that during the COVID-19 pandemic, whenever there is a stigma associated to a medical condition, so people, they refrain from getting medical care or medical assistance. And that basically leads to spread of the disease. So I think this is another area where our national health authorities, they need to work on. Lastly, one of the major challenges that we think is the research part and the innovation part of the work, because there are a lot of gaps and questions about this disease that need to be answered. And especially at our national level, I think we need to develop in-house solutions, especially for diagnostics that are readily available for our provincial public health laboratory network, that can be easily accessed, that are economical. So, and I think this will really help in decentralization of these laboratory network. And just in case there is a surge of cases in Pakistan, so we will need this decentralization of lab facilities in the country. So there are some solutions that we propose, and I'll very quickly go through them because I think there are just 5 minutes remaining. So we need to develop and implement a national Mpox action plan. I think this is a very key solution or a measure that needs to be taken. Already some work is being done on this. During the pandemic, we saw that we were very quick and prompt and effective in developing a national action plan for COVID-19. I think that played a very key role in the control of the disease and in its prevention. So we need to develop that and implement an Mpox action plan at the national level. And again, we will need support from our partners, such as CDC, WHO, and different stakeholders in development of this national action plan. There is a need to strengthen, expand, and sustain lab-based surveillance and diagnostic capacities. I think I cannot emphasize much on this. This is a very huge and a very important area that we make sure we need to strengthen and sustain. Just in case there is a surge in cases in future, this area needs to be properly functioning. And lastly, we need to build capacity for risk communication, basically for, I would say, effective risk communication and for adopting measures that are in our local contexts. So we have seen that effective risk communication, especially with people who are at greater risk. So the population that are at greater risk, they are the people who are healthcare workers, people who have weakened immune systems, pregnant women, and especially we have seen globally that in men who had sex with men. So they are the people who had more disease. So we need to communicate with them. We need to communicate effectively with them, and we need to make sure there's no stigma associated with our with this in order to contain this outbreak in future.